Unlock the future of pathology with Pathology News, your ultimate source for cutting-edge insights, expert analysis, and the latest breakthroughs in digital and computational pathology. Don't just stay informed, stay ahead.
So, with all of that in mind, what we've discussed so far, I kind of want to move the conversation on to what a better diagnostic might look like, and see if you introduce Proclarix. So I was kind of hoping we could talk about that a little bit more. Beat, what would better testing look like in your opinion, and with that in mind, better decision making as well?
Yeah, actually the situation, like Asif described it, is a typical situation, and what we try to do, and we are a spin-off of the ETH of Zurich, so meaning it comes from the academic research. We try to add another clarification step to that decision making. So hence also the name Proclarix for our diagnostic test. So what we in simple terms do is we look for tumor biomarkers, because so far we have the information from organ specific tissue biomarker, PSA, and we add the information, does this PSA value has to do something with tumors. And we summarize all this information and also have an algorithm to give you a risk score. So what's your personal risk of having actually cancer? And this is what Proclarix is able to do in very simple terms.
Thank you. So Asif, I understand that you're actively using Proclarix as a diagnostic. Can you tell me what the boots on the ground experience is as a GP?
Absolutely, yeah. So as a private GP, I'm finding myself obviously having additional reflex tools like Proclarix is really, really useful. It just helps me be able to give patients a bit more clarity. So you'll have a couple of scenarios where I've used it in the past, and taking one scenario is somebody's received an elevated PSA result, not sure what to make of it, but also do not wish to proceed to maybe an MRI scan or a biopsy. So we will then use the Proclarix, and if they have got if their result comes back less than 10%, that puts them in the low risk category. That gives them that reassurance that they don't need to proceed with anything further. But if it's above that 10% threshold, as reported, then that gives them that reassurance or the confidence to say, actually, well, there could be potentially something here, and we do need to progress to further investigation. So it's an added layer of stratification, and actually what it will do is hopefully help. I want to be able to, as a GP in my position, to give my patients as much opportunity to avoid harm where we can. And I think there is obviously still risks associated with having biopsies. Thankfully, we've now moved obviously to transperineal. Previously, they were transrectal in a lot of centres, which had a high risk of sepsis, infection, bleeding, etc., which is still a possibility. So if we can help reduce that, that potential anxiety and that pathway, and obviously pressure and resources, then that kind of works well for me. The second group of people who I've used it with is that they've already been through the pathway, so they've had the PSA, they've been to see the consultant, they've had an MRI scan, but they've been given a result of maybe PIRADS 3. Now, when you have an MRI scan, you'll be graded on your prostate gland, and they'll be either use a Likert score or a PIRAD score. And typically PIRADS is 1 to 5, and if it's 1 or 2, then you're kind of low risk. If it's 4 or 5, then it's high risk. You kind of almost want to be in those two camps, or you don't want to be in the higher camp, but essentially it gives you, you're going to then progress to biopsy. But about 30 to 40% roughly will have a PIRADS of 3. So now they've gone through a conversation with a doctor who couldn't give them clarity. They've had a PSA test which couldn't give them clarity, and now they've had an MRI scan which can't give them clarity, which hasn't given them full clarity. And so you will then find those people saying, well, okay, do I then go to biopsy? And we know that biopsies have got a small percentage of missed cancers as well. So actually, do I go through that process of having needles put inside me, tests done, etc.?
Sure.
So using Proclarix there has been useful as well. in kind of helping identify those patients who may be reluctant to go for biopsy testing.
So, with all that in mind, Beat, I'm wondering, what's your thoughts on the wider, bigger picture here, which ultimately is, patient care? How does this affect patient outcomes from your perspective?
Yeah, actually, what we always try to do with developing a diagnostic test is actually to identify the clinically significant prostate cancers. Now, funny enough, the main benefit of the test is actually to identify the men who are really healthy. So to triage the false positives, and we in clinical trials have found that we can send about 50% of the false positives home through our test. And of course, I told you before that we find also more, which is the second benefit. But it's from our point of view really can be a game changer to triage with Proclarix the PSA results between 2 and 10 again before going to MRI. Because you will avoid these over-diagnostic procedures for the healthy men. And that is a big impact also for
the patient.
And exactly for the confidence in the results as well.
Absolutely. It's rather shocking really that's the difference that it makes. The fact that you can send 40% of testes home and say, no, you don't have prostate cancer. We spoke about patient peace of mind. That's absolutely massive. Asif, I wanted to talk to you about the practicalities of this then. As a GP, is Proclarix a test that you order, or is it something do you send a sample to a lab? How does it work?
Absolutely, yeah. So obviously it's a simple blood test, just as you would have done with a PSA test. So we work with Source Bioscience here, who supply the test. So they will send the kit to me. I'll collect the blood and send it back to the lab, and then we'll get the results back. Usually, in a very well kind of presented patient-facing report, which then I can then pass on to the patient and kind of have a conversation with.
Asif, with that in mind then, how important is it as a GP to have a good relationship with the lab?
Absolutely. I mean, I think and just the fact that we're having this conversation today is already a massive step in the right direction, because the lab and the primary care consulting room, although it may seem, a million miles apart, actually it's all part of the same clinical decision-making process for that patient. So I think we definitely need to be much more integrated and much more, having these open conversations, understanding the challenges and the areas of potential collaboration really in these situations. And I think this is why it's always a pleasure to work with labs to kind of understand, to bring that science, because these guys are fantastically knowledgeable, and obviously people who are coming up with these innovative tests. But it goes back to the old adage that really, you can have all these wonderful tests and actually they're really fantastic, but if they don't translate into clinical practice, for simple old GP like me, if I can't understand that test, or if I'm not educated well enough into understanding what does it mean and how I use that result for my patient, then I'm not going to look at it. I'm going to probably avoid it potentially. And I think this is what we find with reflex testing as well in general, is that I'll get a result, and if that's passed on to another colleague, they won't fully understand, which I completely, there are, all clinicians have gaps in their knowledge, and that's just part of I've got a particular interest in men's health, so that's why I'm familiar with looking at these results, but we're not training all our doctors, and I think that's the important part, that actually we need to make results like this, tests like this, more accessible to other GPs, and so that it becomes more widely understood, utilized, and then also used in a right way, because it's a tool, and it's a triage tool, and actually we can really use it, leverage it to our patients' benefits, to try and get them the best treatment, because at the end of the day, that's all it's about. It's about getting those patients the best treatment.
Sure. Yeah, absolutely. I wanted to come to something that we've discussed at a certain level already, but there's a diagnostic pathway here, and there's use for MRI, which is very expensive. There's also use for biopsy, but that's difficult for the patient, removing tissue. So, Beat, from your point of view, do you think the use of Proclarix reduces the burden on healthcare networks for MRI and biopsy, and improves patient lives in that capacity as well?
Yes, definitely. I mean, it's a relatively reasonable and cheap tool to early identify the healthy men, because still the vast majority are healthy actually.
Yeah.
And also identify more of the critical cancers that should be going through further diagnostics. So it does both ways. It adds a little bit because we identify more, also costs at that point, and it saves because we send people home. Now, the added cost will be saved big time later on, because those patients will not die of cancer and will not be treated with the most expensive drugs, etc. So it influences the whole path of the patient later on, and by doing that, it saves definitely a lot of money.
Yeah. Okay.
Yeah, from a health economic point of view, and I think this is what these risk stratification tools are really vital for, particularly in the NHS where resources can be limited in certain areas. Is having more access to information like this can help prevent unnecessarily further investigations. So I think that that impact is vital, and I think that's essentially what people are looking for, and that's what the government and the politicians are looking for as well.
Yeah, fantastic. Thank you both. And to bring out the crystal ball here and do a bit of perhaps blue sky gazing, how do you think the world of diagnostics will evolve over the next few years? It's amazing seeing these new risk stratification tools come out, in every area of diagnostics. What are your opinions on that? Where will we go over the next, let's say, 5 years?
It's really a crystal ball. So I am from the research side, basically. So I do hope we find more biomarkers like we have found so far. We are. This is the whole history of cancer. You have those stepwise improvements in care, and since I'm in that area, it has improved significantly, and I'm very proud of everything I have lived through.
Yeah.
But it's always just stepwise, and I think we are now introducing this Proclarix, which is a great new stratification tool, but it will not be the end. So I hope we find better tools in the future. Definitely, and diagnostics plays definitely a big role. But also the drugs, I think the treatments are improving. They are also coming to earlier phases that they can add to the cure of the people. So I think it will be everybody together.
Absolutely. I think it's, what really shocks me every day is the biomarker domain. What we're understanding about, my interests are really in pathology and histopathology, and discovering new biomarkers on a daily basis, thanks to AI, really, and understanding all of this big data that's coming with that. I mean, Asif, have you got any thoughts on the future of diagnostics over the next few years?
Yeah, I mean, I think it's the backbone of what we would do in primary care. We use our clinical diagnostics tools, but also having access to these new, novel, fantastic kind of tests. Again, which need to be validated, need to be kind of researched in the UK population, and really it needs to be easily accessible. And those are the kind of tests that I think I know that this is where the whole journey is going. And obviously, I'm not going to touch on AI. You'll know much more about that than I will. I know that will have a huge influence as well. But it is an exciting time because actually, we all want to help our patients. We all want to get them to, either give them clarity or put the early cancer treatment as quickly as possible. And the sad reality is that I think we're predicting about a 14% increase in prostate cancer diagnosis over the next 10 years anyway. So this is a problem that's only going to get bigger. And essentially we need to have those tools in place. So I think there is going to be some huge innovation coming up. I'm excited for it anyway, but I think it gives us more tools for us to deploy in the kind of front line.
absolutely, yeah. And with that, do you think diagnostics becomes more personalised?
Oh yeah, 100% it
Yeah.
has to. Yeah, exactly. That's a really good point, actually. So I think, yeah, it can't be a one size fits all. It does need to be much more personalised. For example, the genomic side of things would be
Yeah.
really important, which is why when my clinical decision making tool is assessing the patient, and I always
Yeah.
go back to that original thing. Is like, okay, well, what does this mean to you? In your personal circumstance, your age, your fitness level, your family history, your
Yeah.
genetics.
Yeah.
It very much needs to be a much more personalised tool.
Yeah, okay. And to really wrap things up then and suppose summarise today's conversation, if you could each change one thing about how we handle prostate cancer screening, what would you say? Beat, let's start with you.
Now, I think do it is my answer. So the screening, screening is done in certain parts of the world in usually clinical trials. So it's still at the trial stage, and it's not covered by states or so everybody's talking about it and everybody sees the need.
Yeah.
But nobody's actually really doing it. And I think this is something that would improve the outcome hugely. And I think that would be my wish, of course, that men have access to something like that. And also, as Asif mentioned, that you can do something with the outcome. So if you identify that you're in high risk of a cancer, that you can actually also cover the further needed diagnostics.
So, yeah, Asif, what about you?
So, some really good points put there. So, not to repeat what he said, but essentially, I think from my point of view, is education. I think for the patients about the screening tools and about getting screened in the first place.
Yep.
So, presenting for these tests is really, really important that men come forward. And then also education for the clinical staff who are then having to deal with the result and how to move forward. And I think that's, in terms of a screening area, in terms of a screening conversation, I think that's probably going to be the one thing I'd like to change, is actually just more awareness and more education around those parts.
Fantastic. Well, today's been such an insightful conversation. It's been a real pleasure having you on at Pathology News.
Thank you.
Thanks so much for coming on, and hopefully we'll meet again and have this conversation in 5 years and see where we are in the world of diagnostics.
Absolutely.
Yes.
That was a pleasure. Thank you, Sidney.
Yeah.
Thank you very much.
Yeah, thank you. And I guess we'll say goodbye to our audience.
Thank you.
Everyone.
Thank you.
Thanks.